Good morning, everybody.
Good morning, sir.
Good morning, sir.
Good morning. So we have post-streptococcal glomerulonephritis for discussion today. You all must have studied number of streptococcal diseases as well as different types of streptococci during your previous classes, right? So can you name some of the common streptococcal infection which has been taught to you earlier? Any streptococcal infection, you know?
Pharyngitis.
Rheumatic heart disease
Yes,
causing
yes, yes.
group A beta hemolytic streptococcus group B, group A.
Okay, can you speak little loud, Arun?
Sir, rheumatic heart disease caused by beta hemolytic streptococcus pharyngitis.
Okay, pharyngitis, right. So streptococci are primarily responsible for skin infection, respiratory infection, and many others, right? More common if we talk streptococcal infection, they mostly include skin infection, which may be either superficial or deep-seated infections. Now here you can see we have two important terms in this topic. One is streptococcus, and second is glomerulonephritis. So this condition is primarily associated with one of the streptococci, which directly does not cause glomerulonephritis, but it is related to glomerulonephritis. As Arun said, rheumatic heart disease, right, caused by streptococci. These agents are not causative agents of the conditions like rheumatic heart disease or glomerulonephritis, but they have some association in these conditions. We cannot directly call them as causative agents, glomerulonephritis or rheumatic heart disease, because there is no direct involvement of this glomerulonephritis, nor in case of rheumatic heart disease. That you need to understand. So it is not to consider them as a cause of Can you hear me now?
Yes, sir.
Am I audible?
Yes, sir.
Right. So we need to know about streptococcal species of streptococci, group of streptococci, which are related to this condition, and about inflammation of the glomerular membrane, glomerulonephritis. Now, another term in the beginning is post. As we said, streptococci are commonly associated with skin infection, respiratory infection, and many other. So some of the these streptococci, after causing primary infection in the form of maybe respiratory infection or skin infection, then in some cases they are associated with some post-streptococcal complications. After primary infection by streptococci, after streptococcal infection, primary infection, sometimes further they are associated with some additional and more severe conditions, complications, which we need to discuss about in today's class. And one of those conditions is the post-streptococcal glomerulonephritis. Before we proceed for post-streptococcal glomerulonephritis, we need to know something about the streptococci, background knowledge of the streptococci, which is necessary to understand the post-streptococcal glomerulonephritis. So before we begin PSGN, I'll shortly introduce with the streptococci. Many of these things you all must be knowing, the general characteristic features of streptococci. These are gram-positive spherical cocci, which are generally arranged in chains of variable length, we should tell. Some are in short chain, some are in long chain, and sometimes even we find them in a pairs also. Now about their habitat, approximately 5 to 15% of the human carry Streptococcus as a normal flora, especially Streptococcus pyogenes and Streptococcus agalacti. These two are the important pathogenic species in the genus Streptococci, associated with respiratory as well as other infections. So 5 to 15% of the humans carry these organisms as a commensal flora of the forming and non-motile, like many other gram-positive cocci. They form capsule and slim layers, which provide them protection, as well as they have got some other functions. Oxygen requirement, if we look, they are facultative anaerobe and they produce small non-pigmented colonies on blood agar. These organisms or Streptococcus pyogenes and agalacti, they do not grow on simple media. They require enriched media in the form of blood agar. Now the organism of interest for today's topic, today's discussion is group A Streptococci. I have not included the classification of Streptococci, but if you can go through your textbooks, you can find classification of Streptococci based on various properties. So there are different types of Streptococci in the form of group A, group B, group C, and others. So organism associated with today's condition belongs to group A of Streptococci, and the important member, important species responsible is the Streptococcus pyogenes. Now, group A streptococcal infections, they are likely to affect all age groups. But if we look at the respiratory infections, they are primarily associated with respiratory problems among the children of 5 to 15 years of the age, while group A streptococci can cause infections of at different age group of the population. As we said, Streptococcus pyogenes is one of the important respiratory pathogen, especially among the children. So about 90% of the cases of bacterial pharyngitis are associated with Streptococcus pyogenes. Streptococcus pyogenes is not commonest cause of pharyngitis. Many of the cases are caused by viral agents, but if we look at the bacterial etiology, bacterial causative agents of pharyngitis, then especially among the children again, then majority of the cases, bacterial pharyngitis is caused by Streptococcus pyogenes. Streptococcus pyogenes is not only important because it is associated with pharyngitis, but more importantly, it is responsible for some other manifestations, more severe manifestations as compared to bacterial pharyngitis. That's why most serious streptococcal pathogen is designated as Streptococcus pyogenes. It causes pharyngitis, that is not a severe manifestation, severe disease caused by Streptococcus pyogenes, but its complications are much more serious than the pharyngitis. Now, a little about its virulence factors. Streptococcus pyogenes have got number of antigenic components, antigenic factors, which are important for their survival as well as they are associated with the pathogenesis. It's got carbohydrate antigen, fimbriae for the attachment, important protein, which is known as M protein. There are different types of proteins like T protein, R protein, and M protein. But out of these three, the most important one is M protein, which is important for survival of the bacteria as it contributes to resistance to phagocytosis, and also it is antigenic. This organism is capsulated, which has high hyaluronic acid capsule. These are some of the toxins, extracellular toxins, which are produced by group A streptococci or Streptococcus pyogenes, which include hemolysins. These are again group of toxins produced not only by streptococci but various other bacteria also, including staphylococci. These hemolysins are of two types. One is called hemolysin O or streptolysin O. This hemolysin is the common term given to the toxins which cause lysis of red blood cells. So hemolysin produced by streptococci are known as streptolysin. So either hemolysin O or we can call it as streptolysin O and streptolysin S. These are named because of their susceptibility to oxygen. Some are oxygen stable, some are oxygen labile. Another important toxin produced by Streptococcus pyogenes is the erythrogenic toxin, also known as pyrogenic toxin, as it is responsible for inducing fever. It's a pyrogenic, as well as it can cause appearance of the rashes. Now, another important hemolysin. As we just now said, streptolysin is a type of hemolysin produced by Streptococcus pyogenes. It is of two types, streptolysin O and streptolysin S. Streptolysin O is more important because our immune system produces antibody-like substance, which is known as anti-streptolysin O. It is produced against streptolysin O. That's why it is known as anti-streptolysin O, like antibody. This is also known as ASO, which stands for anti-streptolysin and O. Now, this is one of the important investigation which is required to diagnose streptococcal infection, not pharyngitis, but other infections that we will discuss. So, increase in the level or titer of anti-streptolysin O more than 200 unit is considered as significant titer, and it is suggestive of past streptococcal infection, group A streptococcal infection. That's why its clinical significance is in the diagnosis of streptococcal infections, but not generally in the diagnosis of pharyngitis. These are some of the enzymes which are produced by, again, Streptococcus pyogenes. These enzymes I am mentioning because, again, during the laboratory diagnosis, detection of these antibodies like substances produced by our immune response are important. You can see streptokinase is an enzyme produced by Streptococcus pyogenes. It is antigenic, and our immune system produces anti-streptokinase antibody. So this anti-streptokinase antibody will be again important like ASO for diagnosis of streptococcal infection. And it has got a therapeutic use also. Since it digests fibrin clots, so it can be used clinically in the cases of myocardial infarction to dissolve the small clots. Hyaluronidase again is an enzyme produced by Streptococcus pyogenes. It breaks down the connective tissues and helps in the spread of organism into the connective tissues. Similarly, we have another enzyme called DNase, which causes hydrolysis of DNA and liquefy the thick pus. That's why in group A streptococcal skin infection, we find thin discharge rather than the thick pus because of the liquefaction of the thick pus by enzyme DNase. Again, it has got diagnostic importance. It's antigenic, and anti-DNase antibodies are produced in response to DNase. So these antibodies are also detected sometimes to diagnose streptococcal infection. So we have a number of serological marker we can say for diagnosing streptococcal infection. We have anti-streptolysin O, we have anti-streptokinase antibodies, and we have anti-DNase antibodies. Right? So these things will during the laboratory diagnosis. Now, in this picture, you can see spectrum of clinical conditions caused by group A streptococci. The most common ones are the skin infections like cellulitis, impetigo, erysipelas, right? These are the common ones. After that, respiratory infection, as we said, streptococcal pharyngitis or streptococcal sore throat is more common among children. Apart from these, you can see, or you must have studied in your previous classes, this necrotizing fasciitis caused by group A streptococci, myositis, and toxic shock-like syndrome, which is actually caused by Staphylococcus aureus, but it can, Streptococcus pyogenes can also sometimes lead to similar condition. Now today's topic, you can see, is glomerulonephritis, post-streptococcal glomerulonephritis. Now, patient who have had streptococcal sore throat are likely to develop complications in the form of glomerulonephritis. The mechanism and other details we have to discuss it now. There are two important complications, long-term complications of group A streptococcal infections, which include, one is the rheumatic fever, as mentioned earlier by one of you, and second one is the post-streptococcal glomerulonephritis. So this condition will be discussed separately during your this cardiovascular system when we discuss about other conditions. But since it is related to group A streptococci, I have just included some part of it. It's one of the complication of streptococcal disease, group A streptococcal disease, and it's an inflammatory condition of the heart, sometimes joints and vessels caused by certain serotypes of M protein. Group A streptococci who have certain serotypes of M protein. For example, M18, M3. That's why we have discussed about this particular protein, presence of this particular protein during general introduction to group A streptococci. So streptococci are responsible for a variety of infections, as we said. Many of them are commonly associated with respiratory infection and skin infection. But certain serotypes or certain strains of group A streptococci which possess this particular component of M protein, for example, M protein M3, they are known as cardiogenic strains, which have tendency to infect the heart tissues because of presence of this particular protein. So they are known as cardiogenic strain. And then after primary infection, either in the form of streptococcal pharyngitis or skin infection, the complication associated is the rheumatic fever. So I'm not going in details of this particular condition because our topic of discussion today is the another condition, that is now post streptococcal glomerulonephritis. Right? So it is the inflammatory conditions associated with streptococci or associated with specific nephrogenic strains. In the previous conditions, we said cardiogenic strain. Here again, the strains are different. Now the streptococci with M protein, which are specific to cardiac tissues, heart tissues, are unlikely to cause post-streptococcal glomerulonephritis. So they have specific type of M protein which have more tendency, more similarity with the glomerular membrane, result into glomerulonephritis. So these are known as nephrogenic strains which cause inflammation or result into glomerulonephritis after primary infection with group A streptococci in the form of sore throat or skin infection. Usually, these features of glomerulonephritis begin after 10 days of pharyngitis and 14 days after the skin infection, although these timings may vary depending upon the individual and type of this strain associated. Generally, it occurs 2 weeks after pharyngitis or skin infection to develop glomerulonephritis. Now here you can see these are the common these nephrogenic or nephritic strains of group A streptococci which have been reported from the cases of PSGN. So we have M-type strains 1, 2, 4, 12, 18, 25, 49 and so on, right? So these are the commonly reported strains of group A streptococci containing specific M protein in the form of M1, M2, M4, etc. Right? So what you need to understand is all cases of pharyngitis or streptococcal skin infection does not does not necessarily lead to glomerulonephritis or rheumatic fever, right? So like we have in last class, we have strains of E. coli, which are important for causing urinary tract infection, uropathogenic strains. Similarly, we have nephritic strains. These are the particular strains which have similarity, antigenic similarity with the glomerular membrane and are more commonly associated with cases of glomerulonephritis. Repeated infections with these strains are uncommon as immunity is type specific. Means person who have had infection with M1 type later on may not develop infection by same serotype, same strain, but there is possibility of infection by other types also. Okay. Is there any difficulty so far? Yes, no?
No, sir.
Right. Now, little about its pathophysiology, right? Now, the exact mechanism of pathogenesis or pathophysiology remains unclear, right? But it is considered as this post-streptococcal glomerulonephritis or PSGN is considered as immune complex mediated disease, right? That's why the causative agent directly we cannot say it's a Streptococcus pyogenes. Streptococcus pyogenes does not colonize neither into the glomerular membrane into the heart tissues. So it is not directly because of the attachment, multiplication and damage caused by streptococci, but it is rather is a immune complex mediated disease. Right? Now, as we said, we have a number of these nephritic strains, nephrogenic strains of group A streptococci. They have antigenic similarity with the glomerular membrane. So, during primary infection with streptococci in the form of sore throat, laryngitis, or skin infection, the antigenic component of the group A streptococci get exposed to the immune system and corresponding antibodies are produced. These circulating antibodies, because of their because of the antigenic similarity, they cross-react with the glomerular wall, resulting into formation of immune complexes, deposition of immune complexes. So molecular mimicry is one of the possible mechanism which describe the pathophysiology of post-streptococcal glomerulonephritis. Due to the antigenic similarities between nephritic strain of group A streptococci and glomerular membrane, the antibody produced against group A streptococci cross-reacts with the glomerular wall, capillary wall, resulting into formation and deposition of immune complexes. Right? So these deposition of the immune complexes activate the complement system, as you all know. This activation of the complement system result into activation of the or release of the inflammatory mediators, activate platelet-derived inflammatory mediators, which leads to activation of production of deposition of cytokines and result into manifested by deposition of the antigen antibody complexes, cellular proliferation, which damage the glomerular membrane. So basic pathophysiology which is related to post-streptococcal glomerulonephritis is due to deposition of immune complexes or due to cross-reactivity of the streptococcal antibodies with the glomerular membrane, resulting into formation and deposition of immune complexes which activate the complement system, resulting into inflammation and damage to the glomerular membrane and nephrons, resulting into glomerulonephritis. Now, overall prognosis, if we look in case of post-streptococcal glomerulonephritis, is good, with a rare possibility of permanent renal failure. It's uncommon and seen only in around 1 to 2% of the cases. The common clinical features of streptococcal glomerulonephritis include hematuria and proteinuria, as it hampers the function of the kidney. So, resolution of hematuria and proteinuria among the children, it occurs generally within 3 to 6 weeks of the onset of the nephritis, and then the children gradually improve, while permanent renal failure is a rare complication associated. Now, a diagnosis generally is based on the previous history of streptococcal pharyngitis or streptococcal sore throat, along with the other clinical findings. Clinical features include fever, as we have seen number of the virulence factors of streptococci. Some of them are responsible for inducing fever also. Fever, malaise, edema, hypertension because of the retention of the fluid, blood and protein in the urine, as we said, hematuria and proteinuria. And this glomerulonephritis generally occurs only in around 0.5% of the patient having primary infection in the form of sore throat. So if sore throat occurs among 200 patients, one patient is likely to develop this glomerulonephritis. So it is not very common, but if it occurs, then it results into the serious complication in the form of post-streptococcal glomerulonephritis. Now, next about investigations. For detection of streptococcal infection, culture can be performed either from the pharyngeal region by collecting a throat swab, or maybe from the skin lesions. Group A streptococci can be isolated, but that does not give you the diagnosis of post-streptococcal glomerulonephritis, because by performing culture we can only isolate group A streptococci, but we are not sure about whether it's a nephrogenic strain or non-nephrogenic strain. But we can isolate the organism from these primary sites of infection in the form of pharynx or from the skin lesions. Rather than performing the culture, especially if we are talking about post-streptococcal infections, when primary infection subsides, so streptococcal detection of streptococcal antibody titer is more meaningful. So that's why we have studied about number of other proteins, enzymes, which are produced by this organism, and against them our body produces antibodies. So same thing, you can again see it here, the list of those serological markers which are useful for detection of past streptococcal infection, previous streptococcal infection. These include again the same hemolysin, as we said, in the form of anti-streptolysin O or ASO. How much is the significant titer we said of ASO?
More than 200.
More than 200 international unit, right? So one is the detection of anti-streptolysin O. So this anti-streptolysin O is one of the important serological marker for diagnosing PSGN, as well as the other complication caused by this organism, that is rheumatic fever. So in both PSGN as well as rheumatic fever, this significant titer or more than 200 international unit of ASO is considered as one of the important parameter while making the diagnosis. So this is most important one. Apart from this, we have these other antibodies in the form of anti-DNase B level in the serum. Also, anti-hyaluronidase antibodies can also be detected. So these are specific to group A Streptococcus. Apart from that, C-reactive protein can also be detected, and we find elevated or increased level of C-reactive protein in the serum because of the glomerulonephritis. Although CRP is not a specific marker, its level increases in any of the other inflammatory conditions. So it should be considered as a marker of inflammation rather than specific to PSGN. Then another important finding, investigation that is required is the kidney function test in the form of detection of urea level, creatinine level, and even sodium and potassium also. So all these investigation can be performed. A culture is not important, as we said, it's a post-streptococcal infection, and organism is not directly associated at the site of infection. Streptococcus pyogenes does not go and bind with the glomerulus. That's why we cannot call it as a causative agent, although it is responsible for the condition, but its direct involvement is not there. So this ASO is a virulence factor we have discussed earlier. It's an immunogen leading to formation of antibody-like substances. We call it as anti-streptolysin O. Anti-streptolysin O is produced against streptolysin O, and see the ASO level start 3 to 4 weeks after exposition and then persists. So ASO level is not useful for diagnosing primary infections like streptococcal pharyngitis or streptococcal skin infections, as its level remains low or undetectable during the first 2 weeks we should tell, while after 2 weeks its level gradually increases, and by the time clinical features of post-streptococcal glomerulonephritis begins, then we can find the elevated level of ASO, so which is more relevant in diagnosing complication caused by group A streptococci rather than the primary infection. And level of ASO elevated after skin infection, or their level titer remains below 200 international unit in case of streptococcal skin infection. Other markers that we have mentioned, there are increases in higher type skin infection as compared to streptococcal skin infections. Now for the treatment, streptococci, antibiotics can be used. Most commonly used antibiotic is penicillin. Those who are allergic to penicillin, other antibiotics can be used. Otherwise, penicillin resistance has not been reported, or it's extremely rare among the group A streptococci. So either penicillin or erythromycin can be used to eliminate streptococcal infections, but it is not for treatment of PSGN because it is not directly caused by the organism. It is because of the deposition of immune complexes. Other options include the supportive therapy, use of diuretics, and antihypertensive to control the blood pressure, and extracellular fluid volume, because there will be accumulation of the fluid and increase in the blood pressure. So these are the treatment options. For prevention, the colonization by group A streptococci is required. Colonization should be minimized, prevented by avoiding the close contact with the suspected patient, screening of the carriers, especially the transmission is more likely to occur among the babies, children in a school center, daycare center, where they are in close contact with each other, and this organism, as we have discussed, is likely to colonize in around 5 to 10% of the normal individual without causing any infection. So those carriers are considered as important sources of infection, and maybe detection of those carriers and prevention by following the respiratory protection will minimize the colonization as well as complications associated with these group A streptococcal infections. Right. So these are some of the things that you need to know about group A streptococci. Then its complications. Two complications we have mostly. One is post-streptococcal glomerulonephritis, and second is the rheumatic heart disease. So, apart from these investigations, sometimes renal biopsy also is performed, and histopathological examination is done. Again, there also we cannot demonstrate the organism, but inflammatory changes can be detected in the biopsy specimen. So renal biopsy is not commonly performed because it's an invasive procedure, but that is also one of the possible option in suspected cases of glomerulonephritis. Right? So these are the things that you need to remember in post-streptococcal glomerulonephritis. If you have any question, any doubts, we can discuss. We have 10 more minutes for discussion. Any questions, please? Any questions?
No, sir.
Okay, if you have no questions, then we conclude it here, right? We'll see you in the next class. Have a good day.
Thank you, sir.
Thank you, sir.